Hi, Tom. How are you? It's Colleen.
Hey, Colleen, are you there?
Yes, I am. How are you doing?
Very well. How are you?
Good, good. I
We
saw
have
that.
a fire alarm going here.
Oh, you do? That's awesome.
How
Perfect.
badly can you hear it right now?
Not that bad. It just sounds like a little like computer notification.
Okay, all right. And then I'm just going to talk from the back of the room. Are you still able to hear me pretty well?
Yes. Yep.
Great. Okay. And then I'm going to go ahead and try sharing a video real quick.
Okay, perfect.
Share down here, right? I can see you, me, and Mandy Clark are hanging out. You're under Maureen's list name, right?
Yes, I am.
Hold on, let me quit that. I decided I wanted to do PowerPoint as showing. And let me go to the beginning. You see my PowerPoint now?
I do, yes.
Okay. And then I want to look at all the details of who's with me in the, how do I?
So at the bottom it says participants. You should be able to click on that to see.
All right, so I'm gonna put participants over here on the side, but you don't see that, right?
No, I don't see that on yours.
All right, I'm gonna.
And then remember, we're doing that waiting room so you can admit people
Right.
in.
Now you can see
now
this
I
thing,
see.
right?
Oh, I see your video.
Awesome. Okay, we'll put that on in a second. I guess we can just leave it on. And so people come on and they're muted. And
Yep.
I'm gonna start so now I can see the slideshow and things like that, but I can also see our video and also the participants.
Oh, okay, good. Yeah, right now I can only see, like I see the picture of you in the video, and then I just see your title slide.
Okay, so I want to see the chat.
And then, yeah, the chat should be like at the bottom of your screen. This is chat.
I don't see chat here. Let's see.
We can test that.
Just trying to figure out how to get it there. Ah, chat. There it is. And then how do people raise their hands?
Well, I just did that to you privately. I said, thanks for joining.
See that?
Yep.
Is there,
And
but there's gotta be a place where they can like turn off all your phones and mute your stuff.
Testing my.
Oh, okay.
I think there's just the chatting. I don't know if you can raise your hand.
We're only gonna use this.
No, I'm just, it's not letting me in, so.
I don't want it to.
Oh, you don't want me to be in?
I don't want you to be in because it totally screws up the
Oh, okay.
system. We're only gonna use this microphone, so.
Okay, no, I was just gonna be muted to see if it was working.
Yeah.
Okay, all right, I'm not in it.
No, don't even do that because that would happen.
Okay.
What's the code? You're gonna sit over here.
What's expected?
Start as a pattern.
I want you to sit over here closer to the screen so you can see.
Okay. This is my
So Tom, would you just plan to let people in like right before 1? So like essentially people are probably joining right now, but they're in like a waiting room.
I just don't know. I don't see where the waiting room is.
Go to participants. Do you see anything there? You should get like a
I
pop-up.
see you and me.
Okay.
I'm out. I logged out.
Oh, is that Amanda? Yeah, Amanda logged with you.
Yeah, I'm sitting here, so I logged out. So
Okay, yeah, because I don't see you anymore.
I can see manage participants, and I see that just you and me and Maureen Corrigan raised hand. So how did you do that?
That was me. In the participant box, there was a hand.
Okay, I don't see that on mine.
I wonder if I could be co-host with you. Hold on one second.
Did you just take over?
No, I made you the co-host. But so I still see your screen. I'm trying to see if there's anything in the waiting room.
You're in front of the
You're way back there. You can. We just want them to see, feel like they're part of the.
Sure. I'll make sure to finish my yogurt before you go live.
I think so, me too, yeah.
Oh, do you want me to then run this? Bless you.
All right, we can run it. I'll run it concurrently, just
Yeah,
because I have my
it's like
notes down here.
Yeah.
so.
Yeah, if someone in the room wants to test joining Zoom, because maybe just people aren't logged in yet. It is 10 minutes early. So Amanda, or if someone else in the room.
Have you try again, and then
Oh,
we'll.
are you going first?
No,
I was going
you
first. You told me that I was going first.
Oh,
That's okay. We can do it. Yeah, it doesn't matter, Tom.
doesn't it? Does it matter? I can change it really
No,
quickly.
you're fine.
You sure?
It literally makes no difference to me.
Wait, but does it make sense sort of thematically to go? Because I have the questions about which one are you doing?
Well, I'm doing
Preferred method.
catheterization, but it's about patient preference at counseling preoperatively. So you could argue that goes
Yeah,
first.
I thought that
or you could, so it doesn't matter.
Yeah, because
Okay. I'm joining again.
Oh,
Yeah.
perfect. So I just admitted you.
You're here.
Oh, okay.
Hi, Mandy.
But-
Yeah. So Tom, it just means that no one else has joined yet. Oh, here.
somebody else did. So
Okay.
why don't you turn yourself off then?
Okay.
I'm gonna have Mandy turn herself off.
Okay. And Tom, do you want me to admit people, or would you like to?
So when they admit, they start hearing us, right?
Yes.
Correct.
Yeah. Why don't you do it at the very end when?
When
We-
more people join.
Yeah, and that's
Okay.
why I put that screen up saying audio will be activated in a few.
Got it. Okay. Yeah. And then I can like do everyone. Yep.
Okay. Thinking about
To
things.
join long enough to get out.
Yeah, just any meeting.
I would have to join enough to get out.
Just as long as your computer is in another room at some point if necessary.
I'm trying to make sure I'm kind of. We have 1 hour total.
Yeah, I'm hoping that you're done by.
Yours is, I think, has more hearty discussion to it. So,
Okay.
I don't know. I think that we can
I
make the
left the
discussion.
meeting.
So,
I mean, I think it's
Just-
like 35, 40 if we haven't moved on.
yes, yeah, we want to be done by like 5 till. We don't want to have any like we want to give people enough time to kind of.
So like 25, 30, we should start.
So I'm thinking this will take like 10 minutes, 10, 15
Okay.
minutes probably when I'm presenting, and then we'll have like 10, 15 minutes for
Great.
discussion.
Great. And again, I'm just gonna lob the questions. So.
Yeah.
Lob the questions to you guys. I'm going to try to keep my eye on like somebody who might be raising their hand
Society of
or
Women
It's a lot
Engineers.
less
Nice.
taking it down to
Exactly.
that people will feel like they can ask any questions,
I
and
know.
if we encourage that, then people will get that more than being like, hi, I would like to be on.
is this the whole group of everybody? Let me close the door.
Although,
But now that the
What is your new address?
2780 Northwest Imperial Terrace,
Wait, I told him that you.
97210. And we're moving actively right now.
Oh, that's what I thought it was.
Beth is
too.
moving the people.
So where are you again?
It's just above Northwest 23rd.
Oh, really?
You're on our side of the river.
Yeah.
We'll have to get together and party.
Yeah. That sounds beautiful.
Only if we
Graduation party at
only if we
Tom's
can join
house.
too.
Yeah.
We'll be back tonight around 7, Tom.
I'll bring mine, don't worry.
So I will maneuver the slides with up and down. arrows here.
Okay.
And you, if you want to
And I'll
just,
do
if you
mine.
nudge me if I'm kind of getting off.
Okay. Okay, that's probably pretty easy because you can see this in your peripheral vision. When this slide changes, then you'll change yours.
And can you be seen? No, I'll have you lean in and say, I'm here when, I'm the first person that can be seen.
No, I
Yeah.
dressed up for this today. I thought we were gonna be on camera, so I dressed nicely.
But I'm okay with not being on camera, so I can just stare at my
But
slide.
now I'm just like off to the side. It's great. Andy, you're like front and center. You're the face of OHS.
She is the face of OHSU urogynecology.
You are. Yeah, hold on. Jenna's hiding herself.
Not anymore, Tom. Wait, is someone gonna be sitting there? No. Why
Yeah, why don't
move
you
the
two-
chair
yeah, move
out
that
and
chair
make
out
it
and-
look-
You may sit over here,
Okay.
or just,
Where,
where should I sit?
yeah. You sit here, Jen.
Just put the jacket down or, there you go.
Yes, you have to get,
Yeah,
yeah.
yeah. But I just need to be able to I have to lean in. It is the idea of flashing on this screen and then not being able to see and then having a high enough resolution.
Here, everybody get in for a selfie here. I'm gonna post this on Twitter.
Colleen, we're doing a selfie in here.
Blake, stand up. Blake, stand up.
Blake, stand
Perfect.
All right.
Should I have
We
all
should
my
switch
journal
that,
documents?
right?
You got to put it on social media now.
Putting it on right now.
Yeah, he's our local social media.
Here we go.
He's gonna take Carl's job.
Very nice. I'll retweet if you put it on Twitter.
I'm doing it right now.
Retweet.
Yeah.
Tweet and then
Hashtag.
retweet.
Get on Zoom right now.
All yours, phones are off.
Yeah.
Mhm.
Yeah, my pager is on, which may happen.
Yeah, mine
I'll
is
just
too.
hand it over.
Mhm. Hopefully the leaf blower didn't come by right as soon as we get started. Oh,
Yeah.
what's that?
Sorry.
Oh, that was my
Turn your
computer.
notifications.
Okay,
Just should be this one, right?
Right there.
That's it. Mhm.
If I just turn the sound down again.
Then you have to turn it back up again.
They even have the trials, the sister trial and Thomas trial, that the avoiding dysfunction piece that was
Oh, yeah.
right. So
I
I
have
have questions about that. So hopefully we are able to discuss it at length, right? Okay. So we got a couple more people.
All right, so far I have 5 people in the waiting room. We can,
Okay, so I can just
yeah, once you tell me, I can admit everyone at the same time. So whenever you're ready to pull the trigger, we can give it a couple more minutes.
up. I did a private message. I don't want to do that. I want to do. Where's my? There it is. How could I change? I want to do everyone. Okay.
You're not in this. You're not in this.
Okay, I can.
Back a little bit.
At the bottom of the chat.
Yeah, I figured that out now.
Okay. Perfect. We got 9 people in the waiting room.
Okay.
You'll be in.
Linda, Jill, Steve. Great. Hi, everybody. Switch over. All right. All right. As long as you get this. What else we got there? Don't do that. Carl, Linda, Steve, Jill Danford, but some number.
Does it matter where our names up there too, so they know there's 6 people?
I'm going to introduce everybody.
Oh, I forgot. I just want them to know that there's 5 more people listening.
Yeah, I'm going to tell people as soon as we get started here. I'm also going to have a phone number. Who has scissors? Oh, cool.
I was just
Uh-huh.
cutting some flyers. Let's try to get this smooth front. A little tabs are good.
Sherelle Glacia.
My cat were here, she'd be really crazy.
All right, why don't we go ahead and admit people and unmute them.
All right, here we go.
And then as people come in, we'll unmute them as well, right?
Yes.
Okay. So Colleen, are we all unmuted? Looks like people are joining here, and I'm assuming that people are hearing me now. And Colleen,
Tom, hi, it's Linda. I'm able to see you and hear you just perfectly.
thank you so much, Linda. Great to.
Thank you for doing this.
Yeah, no problem. So I just wanted to welcome everybody. We have, this is our second of these journal clubs. And I just wanted to, before we get started on the actual things that we're gonna do, kind of just, again, say hello and thank you for joining, and add a couple of sort of just general announcements and housekeeping so we can make this work. So really the main, you're listening in, we're gonna have our journal club here at OHSU, and you're kind of listening in live and you're part of it. I'll tell you how you can be an active participant here soon. So I'm seeing everybody that's on the list as the Zoom conference is growing here of all the participants. And so I can see you there. I just want to make sure that you get an introduction to the people that are here in the room. And so you can see me, great. If not, I can use my words. But first is Ian Fields, who's our second-year fellow, who will be doing one of the presentations. Along with us is Mandy Clark, faculty. Blake Osmondson, faculty. We have Jen Lilleman, our third-year fellow. And then me, Tom Gregory, sort of trying to moderate and maneuver the Zoom conference as well with Colleen's help. And Elena Bennett here on the side, who will be also one of the participants and presenters. And just walking in the room, actually, is Rahel Nardos, who will join us as well. So we have a good majority of our sort of main faculty here. I don't know if some of the folks at Kaiser are going to join us online. You should have received not only the articles to join, to be part of this, but also when you got your sort of confirmation email, you might have also gotten some discussion points that we hope to cover during this talk, but it's really open for how this kind of goes. But I kind of thought it would be useful to at least have a roadmap that we could use to kind of just sort of generate this discussion. As you have joined, your default setting is that your mic and phone is muted, which is great. If you want to talk, that's fine. You can, with Colleen's help, you can raise your hand or just send a little chat message that I'll talk about. To be honest, if you keep your mic and your phone muted, it will minimize other ambient noise and kind of keep the other noise from getting in the way of us having our discussion. But we want to hear from you. As I mentioned, while this is really designed to be a discussion, not really a didactic session per se. So if you have something you want to say or you want to engage, please feel free. We're looking for this engagement. You're part of the discussion. We want it to be that way. I mentioned that you can use the chat feature to post comments and thoughts along the way. I can keep an eye on that and maybe bring it into the conversation as we go along. And like I said, there's actually a place on your menu that you can actually just kind of raise your hand and say, hey, I have a question, and we can unmute you, or you can unmute yourself at that moment. And then just sort of another next steps, we actually have already then settled on the next scheduled journal club. So that's going to be June 12th at 8 p.m. That's Eastern time, 5 p.m. on the Pacific Coast. And our colleagues at University of North Carolina have been so kind as to be the next folks to do this. And so that's great. We'll keep this momentum going. So if that all makes sense to everybody, I think we can kind of get into the meat of things and start with the first article. And I'll have Elena sort of give us an overview of the study, and then we can kind of talk about what it is that we want to talk about.
Great.
Go ahead, Elena.
Great. Thank you so much, Tom. Thank you, everybody, for joining. So I'm going to be reviewing this article by McDermott et al. On postoperative voiding dysfunction and the preferred method for catheterization. So the context for this study is that after pelvic organ prolapse surgery, significant proportion of patients experience temporary voiding difficulty requiring catheterization. And there are 3 methods of catheterization feasible. So one would be clean intermittent self-catheterization, abbreviated throughout my slides in this way, transurethral indwelling catheterization, TIC, or I might refer to it as Foley, and then suprapubic tube, or SPT. And the authors point out that there's some equipoise about which type of catheterization might be best for patients. So patient preference should be included in that decision. Currently, there doesn't exist data on what patients would prefer, so that was the main research objective of this study, was to determine patient preference for one of these 3 types of catheterization. So this was a single surgeon case series of patients who were undergoing anterior and or apical pelvic organ prolapse repair over a 4-year period. So the subjects were recruited after their surgical consent was signed. This included women over the age of 18 who were undergoing the aforementioned surgeries with the study surgeon. Patients who didn't want to participate did not. There wasn't really any further information given on enrollment or power calculations. Measurements that were collected, so the predictor variables, they obtained by questioning the patients and then performing a chart review, so included the ones listed here. And then their outcome, their primary outcome was patient preference, which was recorded at the time of the preoperative visit after counseling. And then they also recorded other data about the patients, including what surgery they had, which they categorized into 4 different sort of categories. And they collected satisfaction data using a visual analog scale, which had been previously used, although I don't think it's a validated survey. And they also reported on sort of perioperative outcomes collected from clinic data. So the counseling before patients made their preference was performed by the study surgeon with a handout that was standardized. And then patients had a postoperative voiding trial in the hospital after their surgery. And then they had a voiding and PVR diary performed. I'm going to adjust myself.
Just a little, there you go.
While they were at home, so they were given instructions for the each type of catheterization, what they were to do at home. Then all patients had a 1-week clinic follow-up visit, where if they were had some form of catheterization, they had a follow-up voiding trial and review of their diary, and they had visual analog scores that survey performed the time of hospital discharge, 1 week later and 6 weeks later. So the analysis they performed, they compared baseline characteristics and surgery category between the preference groups, among the preference groups using Fisher and ANOVA. And then they did multivariate generalized linear models to fit their catheter received with perioperative outcomes and the catheter received with satisfaction scores adjusted for surgery category. So the results, so for their primary outcome of patient preference, just to speak about who the patients were, they had 150 patients enrolled, mean age of 52, 82% of the prolapse repairs were for stage 2 or 3, and about half the patients had urodynamic stress incontinence. Their preference expressed by the patients preoperatively was that 6.7% of the patients desired to do clean intermittent self-catheterization, 7.3% chose an indwelling catheter, and 86% chose a suprapubic tube. For their secondary results, so only 8% of women passed their postoperative day 1 voiding trial. So that wasn't reported exactly as a result, but it was an important consideration. They noted complications. So there were 3 suprapubic tube insertion site infections, 1 suprapubic tube site that had significant leakage, and then 4 that were inadvertently pulled out, 1 which required 2 days of continuous bladder irrigation due to clots in the bladder. And then they reported a UTI rate of 19.7% over the 6 weeks of this study. And that was not different at the 6-week time point among the 3 different catheterization groups. So, sorry, we're flipping slides here. So this is one of their tables. So one of the things that they point out in terms of their satisfaction scores are that, sorry, I'm clicking through here, that the satisfaction scores were significantly different at each time point. However, it's important to note that the preferred method of catheterization was actually different at each time point. So on postoperative day 1, the lowest numbers signified best sort of satisfaction. So clean intermittent catheterization was preferred at post-op day 1. At postoperative sort of day 7 approximately, SP tubes were preferred. And then at the 6-week time point, those who had chosen a Foley preoperatively had the sort of best satisfaction scores. So I'm going to talk a little bit about the author conclusions. So they concluded that when given an informed choice, most patients choose a suprapubic tube for catheterization after their prolapse repair. And they also noted that they thought that the 1-week measure of satisfaction was the best measure. And so they thought that their data supported that patients were sort of best satisfied by suprapubic tubes. They did note that the rate of voiding dysfunction of 92% was very high, although they noted that when similarly sort of stringent measurements were done, it was not completely outside the range of reported of 39 to 84%. They noted no difference in hospitalization or days of catheter use among the catheter groups. And they emphasized that there was a higher UTI rate with transurethral catheterization at 1 week, although notably there was no difference at 6 weeks. And then they thought that their complications with suprapubic tubes were relatively minor. So just sort of assessing the study, a few of the sort of positives. So the preference seemed to be recorded for all enrolled patients for the primary outcome. The treatments for what each patient got was accounted for. There's clear accounting for patients who did not receive what their preference was and why that occurred. And they had relatively low loss to follow-up at 6 weeks. Some concerns. So it was a single provider counseling all of the patients. So they did use a standardized sheet to counsel, but there's always potential for bias in counseling. And then the comparisons, everything except for the primary outcome was compared between groups for what patients received, which was primarily based on patient preference. So it's just important to remember that these are not randomized groups. So thinking about sort of how this study could be applied, the generalizability of this study, this population was Canadian women with pelvic organ. There's a tertiary care center surgeon And they used a very strict voiding trial protocol. So all of those might come into play in deciding whether this study sort of applies to the population that you treat. So I think that's my presentation.
Oh, great. Thanks, Elena. So before I sort of go into these discussion points that we have preordained and prearranged, I wonder if there are thoughts and questions that the group has that either through ringing in or chatting in you want to talk about. I certainly am seeing in the chat, I kind of sort of pushed it out there a little bit, but Steve and Sherelle have sort of kind of jumped on the point about the counseling handout, and that's actually one of the points that we wanted to discuss. I'm just curious if what other people think, if you want to chime in. Okay.
We can go
That's
to
okay.
that
Yeah,
handout.
that's fine. I want to make sure I do. Linda always tells me to wait 7 seconds to expect.
Yeah, let the introverts talk, right?
Exactly. Thank you so much for that advice. You're right. Yeah, we can pop down to that. So let's just take a look at that. I know some people, I'm sure, have read this, but for those who haven't, let's kind of talk through what this counseling was all about.
Sure. So looking through this counseling, they describe it in 3 different ways: how the catheter works and pros and cons of each. And you know, my assessment of it, so how it works, I feel like is relatively accurately described for each form of catheterization. One point of consideration is for both suprapubic catheter and clean intermittent catheterization. They note that catheterization will sort of be stopped as soon as they sort of pass a voiding trial. So for clean intermittent, they say you can stop catheterization as soon as the amount of urine left over is low enough. And for suprapubic catheter, the tube is removed in clinic as soon as the amount of urine left over is low enough. However, actually what they did is that both suprapubic tubes and transurethral catheters were removed at the clinic visit at 1 week. So that was a little bit inaccurate. And then in terms of pros, they highlight some of the things that are positive about each one. And with cons, again, I think these are relatively accurate depictions of potential negatives. One of the comments I see that someone chimed in is that they might not be fully exploring the risk of complication at the time of suprapubic tube. So they sort of list risk of complications at the time of surgery of insertion, very rare, and risk of urine leakage at the time of the tube. And I think it raises an important point about what does rare or very rare mean, and that is a challenge whenever we're counseling patients preoperatively. So in this study, their risk of complications from the suprapubic tube, I think you could argue whether or not it was sort of very rare or not. And they did have, I would say, one sort of more significant complication of a patient requiring irrigation. So there could be some potential bias in this tool that they used. And then additionally, how this is presented, we don't have a way to sort of objectively know, but the surgeon, I think, made an effort to be non-biased in how it's sort of written.
Yeah, I think so. I think that the effort was to try to provide an objective opportunity to look at the different options, but we have some other senior surgeons in the room. Many of the people online, I think, are both all over, but I remember a day when, as somebody asked, did everybody get it offered a suprapubic tube? That was the offering. We did birches, and I didn't do MMK so often, but everybody got a suprapubic tube as part of their deal. And so I think that some people may feel really, really comfortable with the idea that a suprapubic tube is not at all really related to significant problems. But on the other hand, when sitting on my IRB at OHSU, we frequently have to go through potential adverse events or complications as part of the consent for research. And often these things get organized in a way that talks about rare, but the severity of the possibility. So rare and serious would potentially come across as more concerning and maybe would have decreased the suprapubic tube preference. I don't know. That's just something that as you look at the data, it's useful to kind of then peer into the details of the counseling. Let's see, what does Steve have to say here?
I think Dr. Iglesias raised the point that they overstate their rate of UTI for indwelling catheter and CIC, which may have swayed people again towards wanting a suprapubic catheter just because those rates of bladder infection are fairly high.
Great, yeah. So this is, one of the first things that jumped out at me is the patient preference, but
I think as one of those experienced surgeons is that suprapubic catheters are the only one that have the risk of a serious complication. In terms of the bladder laceration, the last one I did, when I pulled it out, it leaked retropubically, and she got bilateral retropubic abscesses after her surgery related to it. And so rare, certainly, but really terrible when they happen. And I don't think the handout does justice to that difference.
right, yeah,
Yeah,
yeah.
I have one question. Would the rate of accepting suprapubic catheter by the patient during the pre-op discussion have been different if a research assistant or an MA had provided this handout? Is it possible that the surgeon conferred something in the discussion that really allowed what I think we were all surprised at the rate of accepting suprapubic catheter?
So I think that's a great point, and I'm sure that somebody's going to bring this up, but that then brings up the question about single institution or single surgeon. It's not just certainly it's the influence, but it's just the generalizability, because clearly we have different practice patterns. And so as we look at sort of what's written in the literature, I mean, and I know that these authors talk about their limitations, but it's something that you always need to keep in mind. I'd like to also just explore a couple of these other discussion points. So like a couple of them are, so we talked about the suprapubic tube preference, but let's also talk about one of the secondary things that they looked at, which is what constituted a past voiding trial. So let's talk about what their definition of past voiding trial is, and figure out whether or not that's something that makes sense to the rest of the folks around the country too. So I'm going to pop back up to discussion point. I have to click on this, back up. Discussion point 1, right?
Yes.
So let's talk about this for just a second.
Yes, so as noted, they had a very strict protocol for how voiding dysfunction was assessed. So they reported that all patients had postoperative day 1 voiding trials, and they actually had whatever method of catheterization they had. So if they had an indwelling Foley, that was removed. If they had a suprapubic tube, that was left in place. But patients were backfilled if they had the Foley, and then they had to void greater than 70% of the backfill, and they had to do this twice and pass both of them to be considered voiding adequately to go home without a method of catheterization. So just how the logistics of the trial worked, of course, was a little bit different for each method of catheterization as well. So for the patients who had a suprapubic tube, they didn't have to have any urethral manipulation during these 2 catheterizations that would otherwise have occurred. So just, it's not clearly stated that was listed in the counseling, but it was more urethral manipulation, certainly for the patients who did not have a suprapubic tube. And then their passage afterwards for patients who did go home with a catheter, so the 92% who went home with some form of catheterization, they were instructed to keep a voiding trial or a bladder diarrhea. So they measured a PVR after voiding for clean intermittent catheterization or for suprapubic tube users. And then if they had greater than 70% of their urine was voided on most voids in a 24-hour period, then they were considered to have passed at that time. Although then they came to clinic and they also did another voiding PVR. For those with a Foley, they just had the opportunity to pass when they came to the clinic at the 1 week mark, and they had to void greater than 2/3 of a 240 milliliter backfill. And then if that was not passed, then they came back another week later. So they did some rigorous work. I see one of the questions posed is sort of how other people do their, if this is similar to your experience. And I think that's an important thing to consider when considering this study, because if many people did not need catheterization, then there would be many suprapubic tubes placed that were just immediately removed.
Mm-hmm.
That change perspective on it potentially. Just reading here.
So what's the question there?
Historically, why did the trend for post-op urinary retention go from suprapubic tube to clean rate catheterization or indwelling Foley?
That's a good question
Yeah.
for us. So
I think
we're
when
older.
the TVT became the most common procedure, we moved from Birch to TVT.
And what part of the Birch or MMK or pubovaginal sling made us do the suprapubic tube? So, maybe there's a couple of other the previous studies, right?
In the late 90s, we had to fight to get cystoscopy privileges.
What else?
And we opened the bladder to see if both ureters were squirting. The bladder was open, so suprapubic tube was placed.
And the suprapubic tube was often a Foley that you inserted through the abdominal wall, which is much softer and more comfortable than the kits. I haven't done a kit recently, but the kits tend to have stiffer catheters.
They're more like PVC piping than.
And they're harder to secure. The pull-out rate on these suprapubic catheters is quite high. And that didn't happen when you used a Foley and stitched it into the skin.
And I also think that however we made these definitions about urinary retention, our understanding of postoperative voiding retention or de novo new problems was much higher in the days of sort of obstructive type procedures like Birch pubovaginal sling. So I think that we had an expectation of, and it perhaps is borne out in the literature, but it's again these questions about what really defines it. It may have truly been higher, or it may not have been truly higher. That's how we practice. I think is.
Can I make one point too that I don't know if it was covered in the article, but I wondered about prior experience with catheterization and whether that actually made a difference in what patients tend to pick. So if patients have had prior clinic cath or UA or whatever, they may actually feel comfortable with that choice as opposed to a patient who's never had prior experience. I see that very much in my patients.
I think you're making a really good point, Rahel. That specific question is not addressed in the paper, but what is addressed is they compared sort of baseline characteristics between the preference groups. And there weren't significant differences, but I will say there was sort of looking at a trend towards those who had a little bit less home support and potentially were slightly older to choose an indwelling catheter, and potentially those are patients who are slightly less healthy. That's just me sort of inferring, but there may be some differences that weren't sort of borne out in this group. Again, we don't have the power calculation to say sort of what they would need because they had very small numbers in those other groups. We would need to see dramatic differences to see it in that table.
Right. They were also older. The patients who chose those two were also older, potentially more atrophy, postmenopausal, wanting to avoid urethral manipulation.
I also want to take a moment, if it's okay with everybody, to talk about actually study design here. So and this is actually discussion point 4 to some degree, and I hope that I'm asking this question right, but basically what I want to know is if you're looking at these results and you decided that you wanted to redo this study based on these data, how would you figure out, again, a prospective cohort design like this, patient preference, how would you figure out how many patients would be needed? What parameters are you looking at, and how could you go about making that design?
Sure. So, and if anyone wants to add to it, I'm just looking at what other people are writing here. I'm going to start answering Tom's question if other people want to join in, but to design a study looking at satisfaction at 1 week, we could use this study because presumably one of the reasons they would have difficulty calculating a power for the studies, they didn't know what people would choose. So if you use this and knew that you were going to have 86% of participants choose a suprapubic tube, then you would need to have a larger population,
Right.
so that, because the smaller groups are what are going to limit your power. And so you would be able to use that, and then you could choose a power of 80% and a sort of a normal alpha, and then you would have to decide what a meaningful difference in satisfaction is too, which gets at a little bit what that measure is. They used a visual analog scale. Ideally, you would use a validated measure, but I'm not sure what a sort of meaningful difference in that visual analog scale would be, and what would be sort of clinically meaningful. And then one consideration would also be, we chose 1 week as the time point because that's what they thought was probably best, but you could argue that other time points would be different, and then you would have sort of different calculations to make. Dr. Brubaker is saying, would it be necessary to standardize approach to urinary analgesics in order to determine satisfaction? That's a really great point. I don't think that was addressed in the article. If people were using Rudium or any other form of sort of urethral analgesic, they use lidocaine at the time of the catheterization placements or that kind of thing, and that could certainly make a difference. Yeah.
Other points here.
I just had one further comment from the good old days when we did so many of these, is that using a suprapubic catheter takes so much of the anxiety about voiding disorder, dysfunction after surgery out. Because the patient has total control with a little valve that she can reach, and she can open it up to let it drain overnight, and then and it's easier for the nurses because the patient can manage it right from the get-go. So there's a lot to be said for that in terms of patient satisfaction, and more attention to safety to keep them from being pulled out. That the pull-out rate for this is quite high, I would think. So.
Well, I don't know if you want to go on to sort of how we're doing on time here, but I think we're about to switch over. So just sort of what, how this article would influence practice. I think it's great to have this mixed group of experience here and nationally, because clearly all of our sort of experience with it, suprapubic tube is not something that I've used very much at all, but for people who are very comfortable with it and have seen patients be very satisfied with it, this study actually may make a lot of sense with their everyday experience, that patients would choose that for potentially the reasons that Dr. Clark was saying. So I think it certainly raises it in my head as something to be considered and potentially included in practice if it would become a feasible part of the operation for patients to do easily, to add it to the counseling of what would they prefer.
Yeah, and I think that that's a great time to do the segue to the next thing we're going to talk about. But I know that the other day I was with one of you fellows. We were doing a case in which I expressed my concern about the likelihood of her returning to normal voiding post-operatively. And of course, the data that we had from her preoperative evaluation, as well as the urodynamic study that we happened to have done, didn't really give us information. So what would be information that we could get and use that could help us predict, is somebody highly likely to have postoperative urinary retention? And if suprapubic tube is preferred, then how do we then choose to put a suprapubic tube in some people and not others? So I do think that's a great time to go ahead and shift over to our next study to look at. So Ian will do this.
So our next study is from Dr. Lindner and his colleagues at Mayo in Rochester. And the title of his study was, Can Urodynamic Parameters Predict Sling Revision for Voiding Dysfunction in Women Undergoing Synthetic Mid-Urethral Sling Placement? So it's estimated that 14% of women will actually undergo an anti-incontinence procedure in their lifetime. So stress urinary incontinence is highly prevalent. And the use of the mid-urethral sling is actually on the rise, especially as women are living longer and getting older. More slings are being placed. So mid-urethral slings are really a mainstay of treatment for stress incontinence. Post-operative voiding dysfunction following slings has been pretty well documented. There have been several studies assessing actually several studies that have commented on that following different slings. So they mentioned specifically, we'll talk a little bit about the sister and the Thomas trials at the very end because they bring that up in their discussion. Despite postoperative voiding dysfunction and retention being really well-known adverse events, studies evaluating the utility of preoperative features and predicting post-op outcomes have really produced conflicting results. So, you know, we know already that the retropubic approach has been associated with increased risk of voiding dysfunction compared to TOT and the Thomas trial. But the use of urodynamic parameters to identify that outcome is actually debated at this point. So really the goal of this was to try and identify certain preoperative factors or features that are associated with sling release, because that can potentially facilitate counseling of the patients regarding the risks, and that actually might influence the surgical plan. So to that end, the objective of this study was really to evaluate the utility of urodynamic studies performed before a primary mid-urethral sling placement for stress incontinence in predicting the need for sling release for voiding dysfunction. So the study design here, this was a retrospective chart review study. This was a study of women managed with mid-urethral sling placement at Mayo Clinic done by 5 different surgeons. And this was over a 10-year period from 2002 to 2012. Their inclusion criteria was patients greater than 18 years old who underwent synthetic mid-urethral sling placement as a primary treatment. In order to try and capture their primary outcome, they excluded patients with fewer than 12 months of follow-up. And their primary outcome was surgical sling release for postoperative voiding dysfunction. And they actually, I think it's important here to point out how they defined postoperative voiding dysfunction was defined as prolonged retention requiring bladder drainage, elevated post-void residual in the setting of new voiding concerns, or de novo onset or worsening overactive bladder symptoms. So their statistical analysis was that they planned to look at baseline characteristics and postoperative voiding dysfunction. We're going to be evaluated with chi-squared or Fisher's exact test for categorical variables and Wilcox and Rank sum for continuous variables. And then they built at the end of the study hazard regression models used to identify risk factors to predict sling release over the course of the study. And then they performed multivariable analysis with pre-selected variables and urodynamic parameters of interest. So they looked specifically at 4 urodynamic parameters: the Qmax or max flow rate, post-void residual volume, detrusor pressure at the max flow rate, and voiding without a detrusor contraction, so those Valsalva voiders. So when we look at the results of the study, they included just about 1,700 women over the course of this 10-year period underwent a mid-urethral sling. 66% of those underwent preoperative multi-channel urodynamics. Of those, 11% were unable to void with the catheters in place at the end of the study. 11% of patients underwent a non-invasive ural flow, so not multi-channel urodynamics. They had a median duration of follow-up of 61 months. And the primary outcome of sling release occurred in 3% of their cohort. So 55% of those occurred because of urinary retention. 35% were new onset lower urinary tract symptoms in the setting of incomplete emptying, and 10% occurred because of de novo or worsening overactive bladder. And the mechanism for sling release was actually different. So this, we'll talk about a little bit at the end, increases their kind of heterogeneity or generalizability. And actually, if you look at how long it took for sling release, the interquartile range was anywhere from 1 to 9 months. So we can talk about these points of discussion too, whether it was simple midline incision, excision of a portion of the sling, sling retentioning without incision of the sling, or a complete removal. So when we look at their, at table 1, this actually shows the clinical and demographic features of the 2 different cohorts, those with no sling revision on the left and those requiring sling revision for voiding dysfunction on the right. So as you can see here, no real surprise here that those requiring sling release were more likely to have undergone retropubic sling placement as compared to TOT. That's been documented in the past, and were more likely to have had a concomitant anterior apical prolapse surgery at the same time, or both. Interestingly enough, if you look here, they also, women who had sling release for voiding dysfunction were more likely to have had multi-channel urodynamic studies performed. You can see they have a p-value there of 0.03, so 80% versus 65%. So when we look at urodynamic parameters in table 2, among those undergoing preoperative urodynamic evaluation, the preoperative values here stratified by need for sling release are shown in this table. And there's no real difference in terms of urodynamic parameters or uroflow metrics with regards to non-invasive uroflow metrics. There's no real difference between the two cohorts in terms of these urodynamic parameters. So when they then performed a univariate analysis to assess the association of individual patient factors with the risk of subsequent sling release to actually find the hazard ratios. And as you can see here in terms of urodynamic parameters up at the top of the table, no urodynamic parameters were associated with the risk of sling release. And again, a retropubic approach to sling placement and concomitant anterior apical prolapse repair were associated with increased risk of a sling release on both univariate and multivariable modeling. In data not shown, they actually adjusted for a sling approach and concomitant anterior apical repair and found that no urodynamic parameter was independently associated with the risk of sling revision for voiding dysfunction. So their conclusions from this study are that there is actually a pretty low rate of sling revision for voiding dysfunction at 3% in this cohort. No urodynamic parameters were associated with the risk of subsequent sling release. And a high proportion of patients, so 66% of patients, undergo preoperative multi-channel urodynamics. The limitations of this study were that it is a retrospective, non-randomized design. There were several surgeons, so 5 surgeons over the course of the study that performed these procedures. Each of those surgeons interpreted their own urodynamics. They all have different sling placement techniques and different sling release thresholds. Although this increases the heterogeneity and may also increase the generalizability of this study. And that this is a tertiary care center, so some may have been seen for follow-up elsewhere, but they tried to account for that in their exclusion criteria when they left out women who had less than 12 months of follow-up available. So.
Thank you. What is it? So yeah, I think an important question that Linda's asking is, will your practice change based on these findings? And
yeah, I don't.
It's I mean, I think that there's a couple of things. So let's kind of break it apart a little bit. And I do have some questions that we had set up. So if the outcome that they chose, so what was the definition of their sort of primary outcome or their voiding dysfunction? So how do they define that again?
So they actually defined urinary retention or voiding dysfunction was defined as prolonged retention requiring bladder drainage, so catheterization of some sort, elevated post-void residual in the setting of new voiding concerns, so not just an elevated PVR on its own, it had to be in the setting of new voiding concerns, or de novo onset or worsening OAV symptoms.
But these were the clinical features that led to the surgeon's decision to ultimately go ahead and do the sling surgical cutting, revision, whatever, right? So their primary outcome was based on clinical decision making that they kind of, and so that number was 3%.
Correct.
Right?
Yeah.
That's a pretty low number to, so let's just hold that for a second. What was the definition of the previous study we just read in terms of voiding dysfunction?
Really strict, like really strict standard criteria. It's objective criteria of like, you have to be able to void so much over.
Right, and what was the percentage who had voiding dysfunction?
92%.
So 80 to 90%.
Right.
Okay, so let's assume that was the sort of the scenario in which we needed to figure out who was going to have voiding dysfunction versus who didn't. It might make sense, assuming that urodynamics actually had something to yield for us, that burden of problems would be worth sort of pursuing, right? If we could find something that could predict it. In this scenario, now with this definition, which, you know, we've done papers talking about surgical repairs. I mean, that's a lot of what we can sort of put together. It seems like it would be a very low likelihood that even something that was really quite striking would be potentially useful. So we have a very expensive test that in this scenario doesn't show us anything to be used for avoiding dysfunction, and the outcome of interest is only 3% of the population. So it's kind of a, it's like at this point, it potentially for this question, there's other questions to be answered by urodynamics, of course, but.
Well, Dr. Brubaker makes a great point here. So she says if urodynamics is performed more selectively, might their outcome have changed? And I think it's interesting because if you go back to look at their table 1 with their clinical and demographic features, the majority of women who had a sling release actually had multi-channel urodynamics performed. So
But that
that's
might
kind of,
speak to their complexity
Exactly.
of their clinical
right.
picture.
And that's what I think
But what
too,
is the number?
because-
It's
So
80%, right?
80%, yeah.
Compared to what?
65%.
Right, so it's not like 80%.
It's not
versus-
overwhelming, but there must be something. That's what I'm getting at. There must be something. There could be something about these women that.
Right, many of us
Right,
are,
it's that patient that I told you the other day. It's like, I have a concern that she's gonna have body dysfunction. Let's go ahead and put the
Yeah.
tube in.
Exactly.
they
Right,
have
so-
something
but
that's
it-
tipping you off to actually do
Right, so it's
urodynamics.
a
prior to
bias.
So it could be a woman who has prolapse and is using pessary but still struggling to void, for example, that you're planning to operate on, and you don't know if with your surgery, she's going to continue to have void. I mean, that's a very clinically savvy, that's the patient I would like to do urodynamics
Exactly.
on, right? Because they might be detrusor under activity or something like that. I was curious, you said 11% of the patients who underwent urodynamic couldn't void with a catheter in. I'm assuming those were excluded.
I don't think so. Those were.
Did they include those patients?
Yeah, they
Was-
didn't analyze.
Because
So
some
am I-
patients didn't get any urodynamics and they're
Yeah.
included.
Because some
Okay.
didn't get any urodynamics, right?
Yeah, so those 11%, I'm actually curious whether or not those are the patients who ended up having voiding difficulty. You know, what is it about those patients that they weren't able to void with a tiny little catheter in there compared to the others?
They did. I don't think they included that data in one of the tables, but it would have been included if it was statistically significant.
Yeah.
I guess my, going back to the question of whether this changes how you would practice, this is getting at the question of, should we be counseling patients differently based on something that we're seeing preoperatively? It changes your counseling on what their risk factor is for potential sling release. I think what's more interesting is post-op urodynamics. What's the role of that in terms of deciding whether sling release is actually going to improve their symptoms or not? The one thing that struck me is that some patients in this that are included are de novo urge symptoms, which is to me not clearly related to a tension from the sling or not. And so having some sort of data that can help you to make those decisions would be a lot more helpful to me. Whereas this is just more about how you counsel patients, and a lot of practitioners decide to do urodynamics or not based on a whole host of other clinical factors.
So Ian's reading Sherelle's comment here about value.
Yep. There were several surgeons involved in that trial, and I'm curious as to tensioning techniques, also decision for TBT versus TOT. That's true
Right,
too,
yeah,
because we know
exactly.
that they already have
Exactly.
different rates of retention afterwards too. So that's a really great point.
And so now in a time when, so 2002 to 2012, I think we were, if I can speak for myself, we still do probably more urodynamics than other sites do, but 66% of the patients ended up having a urodynamic study of some sort in order to try to figure that out. Well, you know, then you go on to the question about the surgical technique for sure. But this question, you know, I think that, you know, how many of your sling patients do you do urodynamics on at this point?
Minimum.
And like Kaiser, I know does very few as
Hardly
well.
any. I don't
right?
remember the last time I did
Yeah.
urodynamics actually.
And then what do we think about the concomitant anterior apical prolapse repair?
So that's a whole different.
Yeah, that's like a whole different thing too, that doesn't even speak to tensioning, but what could be changing about the environment after surgery. So I think that's also an interesting finding in this study.
Again, I like to take these opportunities for both clinically relevant questions as well as sort of statistically based questions. So anything that Linda has to?
She's raising all these, great points about how we need more research in this area. How to prevent the need for sling release. What are the indications for sling release other than complete inability to void?
Right.
And then what
Jen
is
was
the
talking about-
best time to do the
Right,
release? So in this study, it was variable all the way up to like 9 months. Their interquartile range was 1 to 9 months. So that's still something, we don't know.
But we talked about that 9-month sling release and 1-month sling release as being maybe 2 different populations. The acute urinary retention who never passed the voiding trials who get released at 1 to 3 weeks, and the persistent LUTs,
OID symptoms.
UTI in your office every month is going to be the 9-month release, and they're really truly different populations.
With very different expectations for
Yeah.
improvement post-op. I mean,
Yeah. Let's take a moment and just really quickly talk about the difference between table 2 and table 3, if we can. What do you have? I'm just asking about what's the difference between these 2 tables? What's the difference? What's a hazard ratio? Let's talk about what that really means and why table 2 and table 3 exist.
Yeah, so I think you're getting at sort of building hazard ratios as opposed to an odds ratio for something. So hazard ratio is really meant, so when you look at an odds ratio, that's looking at the ratio of something happening to a patient population at the end of the study. A hazard ratio is more of something that happens at any point along a continuum. That's what their risk of having something done. So the risk of anyone at any point in the study of needing a sling release for a retropubic approach is
So is there an
much
odds
higher.
ratio in table 2?
There isn't.
Can we calculate one?
Yeah, I think we can calculate one in.
Right, let's take the one I actually mentioned here. So the actual Qmax variable in table 2. Is there enough information to calculate an odds ratio? Right. So what is the total number? What's the right Qmax? Am I looking at the right stakes here? No, I'm not looking. Maybe I've.
You just need to build a 2x2 table, and you could do it.
Okay. So odds ratio, and then so I'm looking at
odds of having a Qmax less than 15.
Right.
Yes. Is that what you're looking at?
yeah.
I mean, we have rates. We have
Right.
Yeah,
percentage.
6 over.
Okay. Sorry, but so let's talk about hazard ratio then again. And how can the p-values be different between the two to the same thing?
I think the point you're making, Tom, is that there's a difference between 2 and 3, because 3 is accounting for time.
Right.
So with the hazard ratio, you're accounting for people no longer being eligible for the outcome. And so that's why it's not sort of an odds ratio. And another reason an odds ratio wouldn't be appropriate is these are common. While their main outcome was uncommon, these findings they're reporting are common. So an odds ratio doesn't really help you estimate the risk, which is really what you want to know.
So anybody else want to chime in? I think we kind of got a little bit deep into the woods on that one. I see Linda saying it's a very important discussion, and of course our discussion kind of failed to bring up the point, but you do want to look at the data tables as we do these and figure out whether or not they're appropriate, or they can be combined, or they need to be reordered. And so just looking at what's being expected. Let's see. It is 11:52. I want to, I think we've asked the question, is this a kind of clinically relevant question? Can we compare these results to the Thomas trial, to sister trial? Because that's what they did in the discussion. Is it apples and oranges? Is it just the same question with different kind of procedures? How do we kind of use this?
Those trials did not have prolapse repair, correct?
They did not, right? So I think both
So-
sister and Thomas are straight
And
up.
if prolapse repair confers some sort of risk of sling release, it's going to be hard to compare these findings with those trials.
And also, these were pubovaginal slings, birches.
Yeah.
The Thomas was certainly mid-urethral slings
Yeah.
of different sorts. Great. I'm just going to look out to the world out there and see if there are any sort of burning questions that somebody else wants to sort of bring up that we can talk about for like a minute or two. And again, I'm using these 7 seconds or longer to get that.
Hey, everybody, it's Linda. I want to thank Elena and Ian for doing such a great job presenting, and the rest of you for doing a wonderful job with this journal club. I would like just a brief discussion from the audience members and the people at OHSU for knowing what these studies showed us. What are the next big questions that need to be tackled in this area? What do people think are the most important research questions to be answered? I'd love to hear from people.
Yeah, I mean, I think Jen brought up a good point in terms of not only using preoperative, but potentially postoperative urodynamics
Yeah,
as
the big
well.
question is who would be indicated for additional studies postoperatively?
Exactly.
And if so, what are we looking for aside from the obvious obstructive voiding pattern that we might see? There might be some more subtle urodynamic parameters that we don't know yet that might be more predictive of actually, dysfunctional voiding related to the surgery.
I think for my study, I think the next steps would be potentially having counseling by different providers and seeing if patient preference, how patient preference shakes out with catheterization with that. And then sort of what we were getting at is whether patients are actually satisfied with different catheterization methods, which would ideally be done through a randomized trial and then looking at their satisfaction. But
Yeah, I know that some places do, general and every single person getting preoperative counseling about how to do whatever catheterization method there is, and I don't know if all sites are doing that. So does being aware, being learned, being educated about the possibility about doing that, does that change satisfaction and or patient preference? So being aware. So.
Dr. Iglesias making a good point. We need more data on long-term outcomes after sling revision, which would go to like databases, people reporting their outcomes. So for a rare outcome,
Right.
that's the only way we're going to get that data.
So as we wrap up, I'm just going to, because we have just a few minutes, I just want to thank, also Linda, thank you, but Steve Manalia and Carl Gilad, who have been in the background, sort of the curators of the choices of what articles we were going to review and sort of the social media aspect. I mean, Sherelle is on this as well. So getting the word out and being able to have sort of this ongoing synchronous conversation, whether it's by chat or by talking. I think I really liked how this worked personally today. I thank Colleen Hughes also for making sure that the Zoom conference was set up and for her working with me to make sure that our sound quality hopefully was better today. I've got some ideas about how it works pretty well. And then just to restate that the next scheduled journal club is for June 12th. We'll do it at 8 p.m. that night. And we're just gonna figure out whether or not a standard time and a standard day will work for everybody, or I just know that we were already scheduled to do this, and so we had a nice organic conversation here, and I really hope to have organic conversations at the site, so whatever works best. So we'll try next time, June 12th, 8 p.m. And see you all there. So thank you very much, everybody.
Thank you. Bye-bye, everyone.
Bye.
Thanks.
You're welcome. Thanks. Bye.
Great. Great job, Tom.